We could go ahead and start the video. George, I am so grateful to you and your organizing committee and to PMP Research Foundation to go to the effort to get us all together today. I am leaving, George, with you. I know you have a copy of this, but yes. For the Edward Naperville Hospital, the textbook. The textbook, by the way, is the textbook for the European Society of Surgical Oncology course, which is given in Europe and the UK twice a year. Actually, I'm going from here to Manchester to participate in the ESSO course, and we need to do something like that in the United States. But this is for your hospital library. And I'll leave it here. It's 11 videos and 10 chapters on what's been called a final frontier. So let's see. To run this, I'll just give it a click. Use the arrow down at there we go. This video presents let's see if can we turn down the audio on this so I could. I don't know how to do that here. Tell you the truth. There we go. Pull her down. Perfect. Okay, so we've got here 5 peritonectomy procedures. And we're starting off with the anterior parietal peritonectomy. You know, when these tumors distribute themselves, they for the most part settle in, the implants settle in on the quiescent surfaces, not the mobile surfaces. So it's a parietal peritonectomy procedure along with visceral resections. Now, the Achilles heel of this has been what we call fistulas. So the morning I get up to do our cytos 2 or 3 times a week, I'm thinking no enterotomies, no damage to the small bowel. So in order to minimize that, we're elevating the abdominal wall on what we call skin traction sutures. I'd recommend it to you because most of these people have had 1 or 2 or sometimes 3 reoperations. So we've elevated up the skin edges. This is just to show you that this is a true pseudomyxoma peritonei. This is the extensive quartz of mucus ascites, which we remove, and I almost always use a liposucker to get rid of all of this mucus, to begin to decrease the tumor cell load that we're going to have to deal with. Now, a nurse at the National Institute of Health said, you know, your specimens are all kind of ragged. Why don't you try a ball tip electrosurgical handpiece? And you can see that's what I'm working with here. It's a ball tip electrosurgical handpiece on pure cut at very high voltage, and it gives you basically a bloodless stripping of the parietal peritoneum from the underlying structures. So we showed the anterior parietal peritonectomy. That's the peritoneum immediately underneath the anterior abdominal wall. And now as we get out to what's called the, can the lights go down a little bit, do you think? Yes. If the lights could go down a little bit, I think that you would be able to see. Are you able to see pretty well what's going on? Not as good as if we could get the lights down a little bit. So again, you can see that we have this a ball tip electrosurgical device. We have the structures that are to be separated. That's the parietal peritoneum and the underlying muscle or the underlying adipose tissue. We're placing those on strong traction and then separating them bloodlessly with this ball tip electrosurgical handpiece on high voltage. You don't see any bleeding at all. And actually, we can do most of these cases without blood replacement. Now we're starting to begin to work up underneath the right hemidiaphragm, because when peritoneal fluid circulates in the space, what we call the peritoneal cavity, it has a clockwise flow. It goes up the right pericolic sulcus, above the liver, cascades off the falciform ligament, comes down over the greater omentum, and then lodges with gravity distribution in the pelvis. So usually there's a large volume of disease located up underneath the right hemidiaphragm. Now this pink structure up there that you see is the undersurface of the right hemidiaphragm. And we're working along. We've got the anterior lateral branch there of the inferior phrenic artery. We're trying to preserve that so that we have maximal blood supply and function of the right hemidiaphragm. And this is a parietal peritonectomy, so when you get to the bare area of the liver, you can actually bluntly strip the peritoneal surface, which is loaded with tumor, actually infiltrated by the mucinous tumor. And we're making sure not to damage the structures with the heat, so we're using a frequent room temperature saline irrigation. So you're really seeing now the components of the parietal peritonectomy. It's a Thompson retractor that provides this continuous wide exposure of the abdomen and pelvis. You've got ball tip electrosurgical division of the body part from the tumor specimen. And then you've got water cooling to clear the debris away and prevent damage to vital structures, especially tubular structures. Now, I'm getting out to the lateral aspect of the dissection, the so-called lateral arcuate ligament, which comes off the 12th rib. And now I can begin to put my fingers down in underneath the specimen. And it really speeds things up to bluntly resect from posterior to anterior. Now you can see right in the middle of the field there a big tubular structure, and that is the right hepatic vein. And we don't want to damage that, of course. That's a vein that's as big as the base of my thumb, and if it bleeds, it blackens the operative field with blood. So we've started in a counterclockwise direction. We see the right hepatic vein, and then we're separating now the peritoneal reflection of the... Somebody else is trying to hone in on my narration here. Now this is the right retrohepatic space, and we're separating the liver from the peritoneum that's overlying the right kidney. And look right in the background there, you can see the right adrenal gland, and we're very careful not to let's see. We can hear the people calling in, I think, from Elmhurst Hospital. I think that we can, we're hearing the people from Elmhurst Hospital coming into our transmission here. So maybe just hold it down for another 15 minutes, and then we'll come up with the questions.
Will anybody have a question?
No questions now. We're in the middle of the video. Are you seeing the video there? Elmhurst Hospital, are you seeing the video?
We have seen the video. We
you know what? It's my fault, because how about now? I'm speaking more directly into the microphone. I was actually getting up closer to the audience, but maybe you can hear me better at this point. Now, this is the specimen from the undersurface of the left hemidiaphragm. You're not going to be able to achieve a complete cytoreduction with complete removal of these malignant tissues without the peritonectomy. Suction dissection or CUSA dissection up underneath the right hemidiaphragm and left hemidiaphragm. You're just fooling yourself. It's not going to work. So we started off with the anterior parietal peritonectomy, which is that peritoneum which is directly underneath the anterior abdominal wall. That dissection was greatly facilitated with the skin traction sutures. We went then to the, I think you do this, George, also. You go to the right upper quadrant. You want to finish the dissection in and around the liver before the liver begins to expand with the blood, with the fluid replacement that often is required. So now we're over underneath the left hemidiaphragm. We're doing really the same thing over there. We have strong traction on the specimen. We're laying the ball tip at the interface of the tumor and the body part which we're preserving, which at this point in time is the left hemidiaphragm. We're bluntly dissecting when we reach the avascular and less densely attached portions, which is the bare area of the hemidiaphragm, that central tendon. And this blunt dissection goes well as long as you don't push too hard and damage the left adrenal gland. And you can see the left adrenal gland there right in the middle of the little yellow structure right in the middle of the video. And so you're wanting to be gentle when doing blunt dissection in and around that rather fragile structure, which is the right or left adrenal gland. Okay, well, that's the completed left upper quadrant peritonectomy. You can see the heart beating away there. We haven't done anything to interfere with the function of the heart, although you have to be careful with this high voltage electrosurgery when working right underneath the pericardium. So 1, 2, 3 peritonectomies finished in the upper abdomen. Now we're going to the pelvis, and we're starting off by continuing the dissection in the right paracolic sulcus down into the pelvis, and we're working there on the right side, and now we're over here on the left paracolic sulcus. Right now I'm working slowly along the left ureter. We've tied off the left gonadal vein already. Now, an Alice clamp is placed on the urachus. The urachus is a structure at the top of the bladder, and we're now using the urachus as a point of traction to remove the peritoneum from the visceral surface of the bladder. That usually goes well. It's a very nice plane. Not so nice if the patient has had a prior hysterectomy. Of course, removal of the uterus and ovaries is an essential part of this. In some young patients, we do try and do a fertility-sparing cytoreduction, but it only works in a small percentage of the patients. So we have to suture ligate the right and then the left uterine vessels. And after they're ligated bilaterally, you can see we're holding up on the proximal aspect of the uterine artery. We're dividing the uterine arteries on the right and left, and then that shows us exactly where we should go through the vagina. Because one of the areas of greatest density of disease is the cul-de-sac, or the lowest internal part of the human body. So here we've entered now the vagina anteriorly with our very high voltage electrosurgery. This extremely vascular structure can be divided in a bloodless fashion. We've divided it anteriorly, and then we're going circumferentially around the back. We'll go directly across the vagina just below the cervix. You can see the cervix there in the middle of the field. And as soon as we are through the vagina, we begin to see the soft perirectal fat. And we don't have to preserve the mesorectum in this operation. As a matter of fact, we try and spare the mesorectum as much as possible. You can see we've now gained traction on the posterior aspect of the vagina, and now we're performing a cul-de-sac-ectomy. That is taking the peritoneum off the anterior aspect of the middle and part of the upper rectum. We need to clear the peritoneum off of the perirectal sulcus. We do that by maintaining traction on the rectum and rectosigmoid colon so that we can see those precious muscular fibers of the rectum, and we're cautiously releasing the peritoneum of the cul-de-sac from the anterior aspect of the rectum. You can see there's a lot of water cooling. At this point in time, we're using extremely hot electrosurgery, and there you can see the completed cul-de-sacectomy. And now we're looking at the specimen. There is the cervix, and in the recto-uterine space, we have tumor that would never, in any surgeon's wildest dreams, be completely removed with a local procedure. And then we also, in the utero-vesical space above, we've peritoneectomized, and that is the completion of what we call a visceral sparing pelvic peritoneectomy. Now, very often, the disease in the cul-de-sac in the woman or the rectovesical space in the man is actually invading the anterior aspect of the rectum. And in that situation, we are required to perform a rectosigmoid colon resection along with the pelvic peritoneum and along with the uterus, ovaries, and vagina if it's there. Now, we're going to the final peritoneectomy procedure. Most people don't realize that up above the stomach there is a sheet of parietal peritoneum, which is not easy to get at unless you know that it's there and unless you have the proper retraction. So we're now working in the gastrohepatic ligament. And I'm using a profound digital dissection. I have a very important vascular arcade between the left and the right gastric arteries, and I'm pushing the fat and the tumor, and by the way, the anterior vagus nerve, away from these vascular structures, and sometimes that takes me quite a while to do that, but I'm patient. Now I have the left lateral segment of the liver elevated from left to right, and I'm dividing the peritoneal reflection between the liver and the lesser omentum. And you can see there the ligamentum venosum, or the ductus venosus. Watch out for the ductus venosus. You can see it right there in the middle of the field. I'm just now dissecting the fibrous tissue away from the ligamentum venosum. Every now and then it's open. Every now and then it's open, and when you divide it off of its entrance into the left hepatic vein, you can get a major bleed. So always be thinking open ligamentum venosum. Now, this is the anterior aspect of the hepatoduodenal ligament. As you can see, there are numerous tumor nodules involved. I, again, have divided the peritoneal reflection between the liver and the anterior aspect of the hepatoduodenal ligament. And now I'm using a strong forceps. It's called the Russian forceps, to peel that peritoneum off of the anterior hepatoduodenal ligament. And in a moment, you're going to see that I'm also concerned with the disease that's beneath the portal triad and on the posterior aspect of the hepatoduodenal ligament. This is pulling some suspicious tissues away from the right gastric artery. I like very much to preserve the right gastric artery. I think if you have that arcade left gastric going around to right gastric and going over, you'll have much better function of the stomach postoperatively. But it is one of our problems, is gastroparesis after all of this dissection in and around the stomach. And this is the last little bit of a tissue being dissected away from the right gastric artery. And now you can see the caudate lobe coming in beneath, and we're releasing the tissues at the medial aspect of the hepatoduodenal ligament, and we're going to go around behind to make sure that no tumor remains behind the caudate lobe and the posterior aspect of the hepatoduodenal ligament. So we've divided this peritoneum laterally, and then we'll use our Russian forceps, again, our friend, to help us extract the peritoneum from in and around the under aspect of the porta hepatis. You can see there clearly the caudate lobe of the liver. And now our next step is to go one layer deeper. We're going to elevate the caudate lobe of the liver. This is Dr. Bajelik's hands here, and she is actually pulling up on the caudate lobe of the liver. This is up above the stomach. We're going to divide this peritoneal reflection cautiously, because right underneath it is the inferior vena cava, and it's a rather unforgiving surgical mistake to get into the inferior vena cava without any proximal and distal control. So we divide that peritoneal reflection. The peritoneum up here is quite thin. There's not a large volume of tumor in the superior recess of the omental bursa at this point in time, but we're careful to remove it because this is a common site for retained pseudomyxoma or retained mesothelioma. Any of the mucinous, the slimy type tumors, they tend to find their way into the foramen of Winslow and up into the superior recess of the omental bursa. Now we're coming right along the left hepatic vein. We're now skeletonizing the crust of the right hemidiaphragm. And this dissection will then connect up. You can see empty space down there where there used to be peritoneum and tumor. We'll strip that along the lesser curvature of the stomach. And here we're lifting up on that specimen, and it's just now attached to the fundus of the stomach. I'm trying hard here to spare as much of the left gastric artery as I possibly can, and in this particular patient, we can preserve almost all of it. Not always the case, and sometimes the stomach does have a slightly blue and cyanotic hue to it, but you can see here that the vascular integrity of the stomach has been left behind, and then this is the specimen that is the lesser omentum and floor of the omental bursa, and it's really important to get that out of there, and the best time to do it is not on a reoperation where it becomes much more difficult, but at the time of the initial treatment of this appendiceal malignancy. So we just demonstrated 5 different peritonectomy procedures. So we're talking about now the development of HIPEC and also its practice. I'm not going to present a lot of data regarding, I'm going to leave that for Dr. Hantel to tell us what the results of treatment are for appendiceal malignancy, about 65% of patients alive and well at 20 years. Colorectal patients, about 40% with peritoneal metastases alive and well at 10 years. Mesothelioma, 60%. So we have almost untold numbers of single institution studies that would suggest that we can obtain a prolonged survival, and of course there is the Dutch randomized study. So we're really left with trying to use our best knowledge to come up with a best HIPEC. And I'm of the opinion that in order to manage peritoneal surface malignancy, we start with world's best cytoreductive surgery, and we have a lot of teaching and a lot of training to do in order to make sure that all of those cytoreductions that are done around the world are very high quality. And then that surgical complete response should be followed by a procedure to preserve the surgical complete response. And in my opinion, that always starts with HIPEC. There are undoubtedly, over the course of the next several decades, other things that are going to be added on to complete cytoreductive surgery and HIPEC, EPIC, BANK, NIPS, maybe we'll list a few of them. I think that there needs to be an individualized approach that I think I'm suggesting to you that at this point in time, with the data that is available, systemic chemotherapy alone, which is the traditional strategy for managing peritoneal metastases, is no longer optimal. These patients all need to go as quickly as possible to a multidisciplinary discussion. Those patients who are candidates for a surgical procedure should then proceed with the CRS and HIPEC, and those patients who are not can, of course, continue with their systemic chemotherapy. Now, we have a special problem. It's somewhat unique, I think, in oncology, and that's this problem of exfoliation. Now, when we have a liver metastasis, it progresses over the course, say, of a year as a solitary nodule increasing in size, and as it reaches a larger size, it, of course, is going to metastasize elsewhere, especially to the lungs. A peritoneal metastasis is not only going to grow as the liver metastasis grows, but it's going to exfoliate. So in this diagram, we have one tumor cell going to 3, and 3 going to 9, and 9 going to 27, and then you end up with tumor masses of all different sizes. And we see this all the time within the peritoneal space. And you go from one peritoneal seedling to this confluence of disease really in the same time that this solitary liver met would grow out. And it's my opinion that if you make a diagnosis of peritoneal metastases, you need to move rapidly with a treatment plan, because that disease is going to get away from you and from the patient in a very rapid manner. So exfoliation is this phenomenon that we see, especially with the mucinous tumors, but we see it with mesothelioma, we see it with colon cancer. We really see it a lot with ovarian malignancy. Ovarian malignancy can just go like wildfire in the abdomen with this exfoliation. So I'm going to go on. We're not using, at least I'm not using, and we need medical oncologic help here and advice and trials. You know, we rarely use like just oxaliplatinum. Although some people use just oxaliplatinum alone as HIPEC. I think that you'd need to use oxaliplatinum with 5-FU. And that's generally what's done. For me, when I'm doing an ovarian, I don't use just single agent cisplatin. We use cisplatin, we use doxorubicin, and we use systemic ifosfamide. So we're really into multiple drugs with different toxicities as part of the HIPEC. Now, we mentioned that HIPEC is, I think, the standard of care starting. But for example, with gastric cancer, and now in Spain with ovarian cancer, they're starting with NIPS, neoadjuvant intraperitoneal and systemic chemotherapy. We're trying, based on chemotherapy responses, to select those patients who are going to do well with the cytoreduction and HIPEC, and trying hard not to get the gastric cancer patients who, you know, are on this cancer roller coaster and they just don't come off no matter what you do in terms of treatment. We're trying to keep those patients out of the operating room. EPIC, I think, is going to become important, and BANK, bidirectional adjuvant normothermic chemotherapy. I hear there's some efforts now to make this bidirectional adjuvant hyperthermic chemotherapy. In other words, long-term chemotherapy, and perhaps I can make a few comments about that, because I think it's a very important part of our management of ovarian malignancy, and then I take on quite a few mesothelioma patients. It's a part of our standard of care for mesothelioma. HIPEC for me doesn't mean hyperthermic intraperitoneal chemotherapy. It's hyperthermic perioperative chemotherapy. It's both systemic and intraperitoneal. And here's the diagram that shows what we're trying to do. Yes, we're flooding the peritoneal space with a chemotherapy agent, but we're also, shown by the yellow triangles, we're also trying to get a chemotherapy to that tumor nodule by the vascular route of administration. So this is the concept of bidirectional intravenous and intraperitoneal treatments for peritoneal metastases. Now, it's quite clear as to what drugs should be used when. We want to use for HIPEC those drugs which are not cell cycle specific. In other words, they have a direct effect, and they're augmented by heat. And then for the early postoperative period, pemetrexed and for the most part, paclitaxel. Paclitaxel is a standard of care as EPIC for ovarian cancer for us. We would instill the drug for the first 5 postoperative days before those adhesions prevent us from moving ahead. And you can see from this diagram from the animal literature that some drugs, here's melphalan, our backup drug always. And look at the tumor control with heated melphalan as compared to normothermic melphalan. And of course, cisplatin is a good drug, and ifosfamide is also a good drug. The drugs we use, mitomycin C and adriamycin, yes, they are augmented a little bit by heat, but not very much. Some people ask, do you really need to go to all the trouble to have these heater circulators in the operating room to give the chemotherapy? And my answer to that is, at this point in time, yes. They are absolutely essential. Hyperthermia augments the cytotoxicity of cancer chemotherapy. We know that through numerous experiments, both in vivo and in vitro, and it increases the penetration. A lot. It increases the penetration of the chemotherapy into the tissues. And my anesthesiologists are often saying, how long is it to chemotherapy? We're down to 34 degrees. We've been doing a lot of surgery. The abdomen's wide open, and the nurses want it nice and cool in the operating room so they're not so hot, and the patient is getting very cold. So it actually is quite a preparation for a smooth postoperative course. So we want to use a moderate heat and a maximum dose of chemotherapy. That's what Dr. Urano suggested we do. Now, why is it? Why is it? And this is a simple diagram, but why is it that it's of value to instill the drugs directly into the peritoneal space? Well, it's actually very simple. This is the body compartment. This is the peritoneal cavity, and here the tissues are in between with the tumor nodules, okay? So we're putting drug into the peritoneal cavity, and the rate at which the drug is moving through these preperitoneal tissues is slower than the rate at which the drug is being eliminated from the blood or the body compartment. So it's moving slowly out of the peritoneal space and into the blood, and it's moving more rapidly out of the blood and into the urine or being metabolized in the liver. So you will always have, however long that drug is in the abdomen, you will always have an exposure advantage of intraperitoneal administration. And I'm not going to go through this, but this is a list of drugs that we use for intraperitoneal chemotherapy. Prominent ones are cisplatin, oxaliplatin, mitomycin C, and melphalan. And we were talking last night about proactive treatment of pancreas malignancy, which has a terrible record. Actually, the surgery for pancreas cancer is a failure. 60+% of patients have local regional recurrence. I think we can markedly reduce that with intraperitoneal gemcitabine. Pemetrexed is used for peritoneal mesothelioma. And this is a list of drugs that we use systemically. Our most important one is ifosfamide, and then we also use fluorouracil on a regular basis. Now, I'm just going to, these pharmacologic, I've spent 20 years doing this, so I have to show a little bit of our pharmacologic work. This is intraperitoneal doxorubicin. So we instilled the drug. For all of you who are looking at this pharmacologic study, this is the concentration of the drug, okay, within the blood or peritoneal space, and we're measuring that on a regular basis. You can kind of think about that as efficacy. How effective should this drug be based on its concentration and time of exposure? And then this down here is toxicity, because that's the concentration of the doxorubicin chemotherapy in the blood. So here's efficacy, and these are actually the amount of drug in tumor tissue and in normal peritoneum, and doxorubicin has this strange way of being taken up by tissues. But you can see efficacy here is much greater than toxicity. And that is the fundamental rationale behind HIPEC. And we can do it with pemetrexed, very important drug for treating mesothelioma in my experience, a real turnaround for us when we started using long-term intraperitoneal pemetrexed. You can see efficacy, toxicity, greatly separated. Gemzar, very good drug. AUC ratio. So the concentration of the drug that's actually working on the metastases in the peritoneal layer by this study, our so-called AUC ratio, area under the curve ratio, is 120 times. That's pretty good. We've got 120 times the concentration of chemotherapy in the peritoneal space as we have in the blood. This drug is making a revolution of what's called NIPS, neoadjuvant intraperitoneal and systemic chemotherapy. And there are now 2 trials in Japan and another trial in Cordoba, Spain, where the patients are treated for their peritoneal metastases with intraperitoneal paclitaxel or Taxol prior to, this is basically a neoadjuvant, this is NIPS, neoadjuvant intraperitoneal and systemic chemotherapy. And you can see that this is the most, from a pharmacologic perspective, probably the most efficacious drug that we can deal with. We have 1,000 times the concentration, and of course Debbie Armstrong and her group working with ovarian malignancy has demonstrated the clinical utility of intraperitoneal paclitaxel. But you have 1,000 times the concentration of drug within the peritoneal space. Look at this. This is over 24 hours. The drug stays there a long time. And when we do our 5 days of intraperitoneal paclitaxel, the drug dwells for 23 hours. The nurses drain it out, and they put in a new installation. And we have a really very efficacious use of long-term 5 days of intraperitoneal taxane. So we do also, and this is, I'm finishing up with this, we do also now supplement HIPEC with BANK. So all of the ovarians and all of the mesotheliomas at the time of the cytoreduction. So we finish the cytoreduction. We wash the abdomen again with a betadine solution if there's any contamination. We wash with 6 liters of saline with antibiotics. We've done anastomoses and the like. And then we make a little cut down here and we put in a Smith Medical FDA-approved port. And we access it on the operating table, and it stays accessed for 10 days. And we're able to initiate long-term intraperitoneal chemotherapy, what we call BANK, usually about 5 weeks after the cytoreduction. And I don't need to go through this, but we've had good luck, much better luck, or preparation for port insertion than the gynecologists had. Now, in your syllabus, there are a number of different chemotherapy regimens, which I'm not going to go through. because it would take too long, but I'm going to end on time with these conclusions. Peritoneal metastases can be prevented. We didn't even talk about that because we didn't have time. But there are a number of prevention protocols for gastric cancer, colorectal cancer, and we and one other group are using it for pancreas. Prevention is probably our most powerful tool. In the next decade, I think prevention will be what's most important about HIPEC. I don't think that single-agent chemotherapy is enough. I think we need to work with medical oncology and our experts in the field to come up with 2 and 3 drug protocols that are effective but also safe. I like to use bidirectional chemotherapy and the early postoperative chemotherapy. I wish I could tell you that there are a lot of treatment protocols trying to compare one drug to another. What we're now doing is registries. And the registries, the mesothelioma registry is now 1,500 patients strong. Winston-Salem's going to have an appendiceal registry that's going to be about 5,000 patients. So we're going to compare one institution to the other and one treatment plan to another, and hopefully we're going to be able to tell, based on these multi-institutional studies, which will benchmark one institution against another, we'll be able to make some conclusions as to what's the optimal treatment. A huge part of this is, and I'm sure you've got that going on here, is a comprehensive morbidity, mortality assessment that goes on all of these patients. Our patients are extremely carefully monitored in terms of what happens to them. Yes, they stay in the hospital a long time, but 3 months later, their quality of life is, for the most part, actually almost without exception, back to, we have Brian Logie to thank for those excellent studies. There's a lot of phase 2 and phase 3 trials going on. There's about 20 different phase 3 trials going on around the world in ovarian cancer, in colorectal cancer, in gastric cancer, and we're eagerly awaiting the results of those. They're a little ways away, but we're going to review them and try and come up with new thoughts on what direction our clinical research will go when we come to November 17 through 19 of 2016, when we'll have the 10th biennial meeting of the Peritoneal Surface Oncology Group in Washington, D.C., and I'm hopeful that we'll see a goodly number of you there for that meeting. George, that's all I got to say.
Thank you.